Good afternoon, everybody, and welcome to SADS Live number 140, 140. It's great to be with you this afternoon here in Central Standard Time of Rochester, Minnesota. Those on the East Coast or across the pond in the evening, you're getting settled or have had dinner. Anybody down under, it's great to have you with us. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and its complementary Winland Smith Rice Sudden Death Genomics Laboratory. As you know, we are devoted to families with SADS condition, but as in the past, I'm here on behalf of Alice Laura, the CEO of the SADS Foundation, where I've had the privilege of serving as president of its board since 2006. The SADS Foundation is Sudden Arrhythmia Death Syndrome Foundation. You can find us on the website www.sads.org, SADS, or if you like to prefer, www.stopsads.org, because that's fully our intent. We certainly are geared to stopping the fear associated with these conditions, living with these conditions, so that you can live and thrive. You know, that's a phrase that I've embraced and have shared. And a really cool story. I don't know if they're joined online today, but if they have, shout out to them. I met a wonderful family and was excited to see that, to have them share that they raise race horses, and they named their last horse Live and Thrive. So maybe sometime we can get them on or get a picture of their horse. They're going to send it to me. I haven't received it yet, but their horse, Live and Thrive. And I love that. Well, we have a wonderful program, and we'll get going with it because I'm really looking forward to this conversation with Mrs. Laura Rust, a colleague of mine here at Mayo Clinic in Rochester, Minnesota. And she's going to be perfect for the purpose of what you have had many questions. As you know, last month, we were focused on pregnancy with families, individuals with SADS conditions. What is it like for the mother if she has a SADS condition? What is it like for the mother if she's carrying a child where her husband has a SADS condition and therefore the baby has a 50% chance of ownership of that genetic heart condition, at least at the genetic level? And so to deal with all the questions about pregnancy, should it be called a high-risk pregnancy? What does that mean if you get labeled high-risk pregnancy? What if you want to do in vitro fertilization and you've heard about this thing called pre-implantation genetic testing? What does that look like? And how does one go about doing that? And what things should you be equipped with to know what kind of questions to ask if you're considering that pathway to procreation? So without further ado, Erin, as the wonderful person she is and the magic of our SADS Live program, she's going to bring on Mrs. Laura Rust. And here she is for her debut to SADS Live. Welcome, Laura. It's great to have you, and thanks so much for doing this.
Thank you for having me join. I'm excited about our conversation today.
Well, I know to those who are in the genetic counseling world and are a professional genetic counselor, they're going to be so happy with me that I have another genetic counselor on board, because we've had a few of the 140, but maybe not enough. And so for the genetic counselor community, this one's for you all out there. But before we look at high-risk pregnancy and the setup that I gave, there might be one of our SADS kids, adolescents, young adults who's actually thinking about a career in genetic counseling or to be a genetic counselor. So maybe share your from here to there journey so far.
Yeah, certainly happy to. So my journey started in undergrad. I was a biology major at the University of Wisconsin-La Crosse, so just about an hour from Rochester here, and wasn't totally sure what I was going to do with that, but I took some genetics courses and really liked learning about genetics. I found it very interesting and engaging. And I had a friend of mine from high school who had a genetic condition that it just really resonated with me, that I was able to connect with his specific diagnosis through learning about genetics. When I graduated, I wasn't totally sure what I was going to do with my life. So I ended up actually here at Mayo working in the cytogenetics lab for about 5 years. So doing clinical testing of chromosome analysis and things like that. But through that, met some genetic counselors at work for the labs here at Mayo, and kind of recognized that was maybe my calling. While the lab work was really interesting, I wanted to engage a little bit more with a patient-facing role. And so I left for 2 years, went to the University of Wisconsin-Madison for graduate school. Genetic counseling training is about a 2-year program. So I went there and graduated in 2015 and came back to Mayo, and I've actually been here ever since. So I'm just coming up on 9 years back at Mayo as a genetic counselor.
And your specific area of genetic counseling is did it start and stay in maternal fetal medicine, or did you more recently move to that?
It has. I've actually been in this role for all 9 years.
Wow.
So I am supporting kind of our division of OBGYN. I see routine low risk patients in our OB clinic, but also the higher risk patients in maternal fetal medicine, as well as we do quite a bit of preconception work for maybe when a family that we know has a genetic diagnosis or who's interested in going through reproductive endocrinology, in doing pre-implantation genetic testing or other sort of preconception issues.
Wow, great. Well, then you are perfect, as I knew you would be, for the many questions that our SADS community has been wondering about. And I know I have questions in mind for our conversation, but for those of you out there, I'll be looking on the side to the comment line and seeing what questions that you have in real time, and I might pose them to Laura's way. And I'll start, Laura, with one of the things that I've seen as probably the cruelest expressions to my families is heart rhythm doctors, cardiologists, well-intentioned as they may be, I'll give them the credit for that, telling my patients, you should never get pregnant. You should never have a child with one of these conditions. And I just think that's just beyond cruel. So my premise is that with very few exceptions, every one of my SADS families, my young women, middle-aged women, whatever age, who wants to procreate, that we can do a child and we can navigate pregnancy, labor, and delivery, and we can navigate, yes, maybe the baby will or will not inherit mom or dad's thing. And so we can do that well. And so we encourage pregnancy and so forth. So with that, I view most of my patients as low risk, but if they get called high risk pregnancy, I don't know that our SADS families really know, what does that designation mean? What does that trigger or do for their OB pregnancy duration, labor and delivery, and so forth?
Yeah, great question. I think certainly there is this, sometimes we throw around the term high risk just to indicate who should be managing that pregnancy. I can share a little bit specifically about our practice here at Mayo. We have certified nurse midwives that manage a lot of our low risk pregnancies, but that particular group might not feel as comfortable managing a pregnancy where there's maybe different medications that we need to adjust or things like that. So sometimes we say, well, they're higher risk just because they would really maybe benefit more from an obstetrician, maybe maternal fetal medicine, which is like a higher level of care. Our maternal fetal medicine team acts sort of like as a consultative service, which means we often will send our patients to one appointment with maternal fetal medicine, and they can sort of review their history, their medications, and make recommendations back to their OB to say, well, these are the situations where we would consider it high risk, but as long as things aren't changing, they can sort of be considered average risk and let their OB manage the majority of that pregnancy.
And if they get called high risk, does that translate into more frequent visits or more in depth or both?
Usually more visits. And then often as somebody is getting closer to delivery, there might be situations where there's more frequent ultrasounds. A lot of people who are average risk might only get 1 or 2 ultrasounds throughout their whole pregnancy. But if we know there might be higher risks of fetal arrhythmias, for example, right, that can sometimes happen in some of these conditions. And then if there is a fetal arrhythmia, that can then lead to some downstream effects where we would want to be monitoring those pregnancies more carefully. So yes, it probably would mean more frequent appointments and more frequent ultrasounds. Sometimes it changes delivery planning of saying, well, this is really a situation where we'd want somebody to be delivering in a larger hospital system, just in case things don't go the way we're expecting. The last thing we need is somebody on a helicopter going to a tertiary care center or things like that, and families getting separate, babies one place, moms another place.
Right. But a high risk designation, that doesn't mandate or imply an expected C-section delivery, does it?
No. Good question.
So, because we also have obstetricians, I would say, who are not familiar with SADS conditions, and then they view the mother who has, say, long QT syndrome or any of the conditions that we focus on at SADS Foundation, long QT, CPVT, Brugada, and so forth, where they kind of imply to the mom, thou shalt have a C-section type thing, when the vast majority of my long QT moms is completely dependent on obstetrical criteria, not cardiac criteria.
Yes, agree. I think, yes, that should be the majority of the cases, that C-sections are because of baby is breech, or there's some good obstetrical reason to do it, not because of the maternal health condition.
Mm-hmm. And as a genetic counselor in OB and maternal fetal medicine, we'll focus on SADS conditions, but in general, what are the scenarios in which they are looping you in as a critical member of the OB or maternal fetal medicine team?
Good question. There are a couple different touch points that a genetic counselor might have with a patient in OB. In many cases, it's for routine things. All pregnant patients are offered screening for chromosome conditions like Down syndrome, or doing carrier screening for recessive conditions like cystic fibrosis. So we often are just seeing routine patients kind of regardless of their history. In the maternal fetal medicine category, these are situations where we might be offering more than routine testing. Maybe that's because there is a genetic condition that one of the parents have, or they're both carriers of, that we want to talk more specifically about how we could test the baby for that condition, either during or after a pregnancy. Sometimes it's because there was an ultrasound finding that's concerning for a potential genetic explanation, where we maybe don't have something specific we're looking for, but we're casting a wider net to look at all of the chromosomes, or maybe do whole exome sequencing, kind of looking for a lot of different things at the same time to see if we can get that family answers for why we're seeing what we're seeing on that ultrasound.
Okay. And now with our family specifically, they know they have long QT, almost all of them. They know their diagnosis.
Right.
They presumably have their diagnosis being treated and addressed. They now come to me for pre-pregnancy counseling. We're thinking about getting pregnant now. What does this look like? Should I be called high risk? My OB thinks maybe I should. When you receive a long QT mom, where the baby by definition has a 50-50 chance of inheriting mom's thing from Dr. Seuss, right? Thing 1 or thing 2. Mm-hmm. What would there be anything specific for that long QT mom as a high risk classification, or would it be part of the standard drill?
Yeah, so there, in that situation, if that patient is referred to me, certainly I would talk in a little more detail about options for finding out if their baby did inherit that mutation or not. We can do prenatal diagnosis. It does require either taking a biopsy of the placenta, which is usually done between about 12 and 14 weeks of a pregnancy. And that's called a chorionic villi sampling, or a CVS. Or testing can be done a little bit later on amniotic fluid, usually after 15 or 16 weeks of a pregnancy, where we can see yes or no, did they inherit that mutation or not? And at least put that question to rest of, did they inherit it or did they not? Both of those are procedures that do carry a small amount of risk of complications from doing those types of prenatal diagnostic testing. And for some people, they're maybe uncomfortable with the idea of doing invasive testing. And so in many cases, we're actually arranging for the umbilical cord blood to be collected at the time of delivery to be able to do that testing, so that we have that information within the first few weeks of life. But also we don't have to poke anybody. We don't have to poke mom. We don't have to poke baby. We can just take the blood from the umbilical cord and do that testing then. So some of it's just the logistics and coordinating for something, again, more than routine.
Right.
Those people would also be offered those routine screens, like screening for Down syndrome and trisomy 13 and trisomy 18 and carrier screening. So some of it is the status quo. They should get offered the same thing as anyone else, but also, are you interested in diagnostic testing for your baby? And if so, when is that that you might be interested in doing that?
And it seems like maybe it's because of the nature of our Winland Smith Rice Genetic Heart Rhythm Clinic, but I would say, golly, 99% of our families do the post-birth umbilical cord assessment of, did the baby, yes or no, inherited the thing, as opposed to finding out in utero. Because I'm not afraid of it, meaning I'm not afraid if the baby were to have inherited the CPVT or the long QT. And so for those families, if I'm not afraid of that, then that little risk that you mentioned from the sampling of the placenta or sampling of the doing the amniocentesis, and that little risk, is that what you're referring to, is that might induce early labor and then lose the fetus?
Yes, that's one of the risks. And we usually say it's like a 1 in 500 chance, or 1 in 1,000 chance even, but it's not zero. So you do have to weigh those risks with the benefit of knowing the information during the pregnancy or waiting.
Right. So
everybody's different, right? So some people feel like, I can't sleep at night. I would just really like to know this information now, just to know, maybe it doesn't change anything about the way their pregnancy is managed. They just, feel like they would like to know. And other people are comfortable with the idea of waiting till delivery. And, they've known their whole lives it would be a 50% chance that it gets passed on.
So when the mom and the dad create their baby el naturel, and have that 50-50 chance. So we know it's a 50-50 chance. But if the family wants to make it not 50-50, but 0, that usually brings us to the world of letters like IVF and pre-implantation genetic testing and stuff like that.
Yes.
When they ask us that, and then I send them to you, what happens in that first conversation where they say, we want to make sure our baby does not have my long QT, does not have my ARVC, my hypertrophic cardiomyopathy, my whatever. And then I say, okay, in that case, let me bring and introduce you to Laura on our team. What does that first pre-conception, pre-IVF session look like?
Yeah. So often we'll set some time aside to just really focus on the high level of what to expect if you were to go through this process. I often find that there's sort of this idea of like, you could just do IVF and test embryos. Like, this is great and easy and just go do it. And unfortunately, it's of course not that easy. And there are a lot of steps along the way. So I think my goal in those initial conversations is really to prepare people of, how long is this going to take? What is the cost of doing all of this? Is this in line with your values and goals for growing your family? it can be overwhelming sometimes to learn all of this information, or just learn that it's not as simple as it sounds. So, I think starting with just the process of in vitro fertilization, that is required to create an embryo, and just understanding what that full process is truly is best described by our reproductive endocrinology team. And so often it requires then a referral to that team to, understand, are you a good candidate for IVF? Some people have never tried to get pregnant before, so they don't know. Maybe they actually have some underlying infertility that might make IVF really difficult for them. Those fertility evaluations often take several months, which for some people is very unexpected. That, there's different lab values that need to be checked on certain days of a menstrual cycle. And so sometimes you've just missed that and you have to wait till day 3 the next month. There are ultrasounds that are done of the uterus and the fallopian tubes and the ovaries to calculate the ovarian reserve and make sure there's no endometriosis or fibroids or, other factors that might make this sort of treatment difficult or more challenging. There's a semen analysis involved to make sure there's no male factor infertility and all of this, all these different referrals and workups. And sometimes we even find that certain fertility clinics aren't comfortable if there's specific diagnoses, and it might not even be like long QT or one of the SADS conditions. It could be other health conditions that somebody has that certain clinics might not treat certain things. And so it requires travel and all these things. So, I think just setting that expectation of IVF is a beast. It is a time intensive process. It is probably, I usually tell people, expect from the time you get a referral to the time you would have even an embryo available to transfer is probably on the timeline of 6 to 12 months.
Wow.
When
I think that's so important with what you do, Laura, is that, families have, we'll just do IVF, like you said, and nobody explains to them that it's actually very involved. It's not just boom, boom, we're going to do it this way. You said from green light go to transferring the embryo in because you've tested the embryo and he or she is clean, could be 6 to 9 months. And then that starts the 9-month pregnancy.
Right.
What's the cost? Because I've heard numbers and I don't even want to say the number I've heard because maybe I've been way off, but
yeah, it is different depending on where you live. In the United States, the average cost of doing one round of IVF is about $25,000. One round.
And not covered, right?
It sometimes is. That's one thing I always tell people is check your insurance and your employer benefits, because sometimes there is coverage for IVF or other fertility treatments in general. So definitely check those benefits. I have had some insurance companies that say that they'll actually cover the genetic testing piece of testing embryos that are created through IVF when we're looking specifically for an inherited genetic condition. But some of those families, if they don't actually have underlying infertility, don't get the IVF piece of it covered. Wow. So definitely, I think it's good to check into those benefits just to know if you would have some sort of assistance of, financial coverage. There are some grants out there for couples, especially when there is some sort of known inherited genetic condition. There's different groups out there like the Resolve Network or Fertility IQ that list different grants and charities that might be something to look into. And there's even like loan servicers that offer low interest loans for the sole purposes of fertility treatment. So I think knowing that financial landscape is definitely important. As you're financially planning for all of this, though, the other thing that is sort of a bit of a downer is that almost 50 to 60% of people who do IVF actually have to do more than one round to create enough embryos. So sometimes it's that cost times 2 or 3, depending on how many embryos were able to be created.
And because of that cost, which is not trivial, is that why in the past they would implant multiples, hoping that one would go and end up with twinning? Has that changed over the years, where now you and the team recommend doing at most 2 embryos transfers, or is that so variable?
It's probably variable based on clinics. I can say one of the things that has definitely changed over time is when embryos are tested for like a specific genetic condition. Often that is also including testing for aneuploidy or chromosome differences, because those are some of the most common causes of miscarriage or failed implantations. We think about half of all miscarriages are because of a sporadic chromosome abnormality completely unrelated to a SADS condition. That is becoming more common practice, even for people that are doing IVF for fertility purposes and not because of a genetic condition. And so when we know we're transferring what we call a euploid, or an embryo that has a normal set of chromosomes, that we're kind of controlling for that risk factor of miscarriage, many clinics now only will transfer one at a time, because we're we know what we're transferring. In the past, if embryos weren't tested, that was maybe sometimes where 2 or 3 or more embryos were getting transferred at the same time, because we didn't know if there was a genetic risk factor for miscarriage.
So the IVF is successful and an embryo or embryos are created. The last family I saw, they told me that they had X number of embryos that were, I think, A plus or some grade. So these lives, they're getting graded?
So there is a grade based on how those embryos look underneath a microscope. There's different criteria that the IVF labs will use. Grade A being your kind of best morphology. It looks the best underneath the microscope. When it comes to like the decision for which embryos to transfer, the genetics are incorporated into that. Did it test positive or negative for the mutation we were looking for? Are there chromosome abnormalities? Most often, if that answer is yes, those embryos are not offered for transfer. And then is it grade A or is it grade B? So there's different criteria that are used to decide which embryo is going to be have the highest chance of success in resulting in a live birth. The challenge, of course, is even that best embryo, that euploid, normal chromosomes, that is negative for that mutation, that is grade A, maybe has a 50 to 60% chance of resulting in a live birth after all of that. So, sometimes it even still means multiple transfers are needed.
That's fascinating. That's absolutely fascinating. So we have a grade A under the microscope embryo live. Then you said they get a genetic surveillance, and part of that is a general genetic. Do they have the right number of chromosomes, euploidy? But then because it's a family with one of our genetic heart conditions, they're being tested. The embryos, are they being tested exclusively for mom's thing or dad's thing, or are they being tested for like a fresh batch of everything?
Great question. Typically only the known mutation. And that is actually one of the challenges of this testing, is it does require that mutation to be known. And we also know that there are a handful of people with a SADS condition, clinical diagnosis, that have had completely negative genetic testing. So this essentially is not even something that is an option if we haven't identified the mutation. Embryos, they're tested. So like in the IVF lab, you have egg and sperm come together, and that makes an embryo, and we call it a day one embryo once that they've been put together. And that one cell will then start growing and dividing until around day 5 or 6 of development, it's somewhere between 1 and 200 cells at that point. And that's when we actually do the genetic testing. What's kind of cool, we call those blastocysts when they're 5 or 6 days old. And what's kind of cool about that is you can actually start to see the outer layer of those blastocysts. We call it the trophectoderm, which eventually becomes the placenta once that embryo gets transferred. And about 3 to 10 cells, probably maybe 5 cells are removed from that future placenta layer for the genetic testing. Embryos have to then get frozen. We can't leave them growing. They won't survive much past about 7 days in that Petri dish. But really, when you only have that limited amount of DNA, it's really hard to test for more than just chromosome abnormalities and one or, and sometimes there's 2 mutations or 2 conditions we're testing for. But there's not a ton of DNA to be able to do like whole exome or whole genome sequencing. It's probably coming, but at this point, the current state is the vast majority of the time it's really targeted to just the one condition we know is present in the parents.
So the day 1 embryo, he or she gets to grow and live, and at about day 5, when there's 100 cells, you're able to select just a small percentage of those 100 cells, 3-4 cells, to get enough DNA to ask the question, does that embryo own mom or dad's thing that we know causes long QT syndrome, ARVC, whatever?
Correct. Yes.
And taking those 2 or 3 cells from that 100-cell blastocyst embryo, does that damage the future baby in any way, or is it no big deal since those cells are going to become the placenta and not the baby? Is it of no risk to the developing embryo?
Yeah, embryos are pretty hardy, actually. So it sometimes is surprising if you've ever seen you can look them up on YouTube, an embryo biopsy, and sometimes you watch them and you're like, oh my gosh, how is that not damaging the embryo? But embryos are pretty hardy. When we look at the data of comparing embryos that were biopsied for genetic testing compared to other IVF pregnancies, where genetic testing was not done, those embryos were never biopsied, we actually don't see any significant difference in the rates of like birth defects or pregnancy complications, or, we don't think that biopsy is causing any complications during a pregnancy. There are questions about, whether or not that could affect the chance of implantation. We see pretty equal rates of like those implant into the uterus once they're transferred. But that, there's sort of this question of like, well, if it didn't implant, was it because of the biopsy, or was there a different reason why it wasn't a successful transfer? The other thing is, truthfully, anytime you manipulate an embryo, whether it's freezing it, thawing it, or biopsying it, there's a small risk you lose that embryo, sort of like that it just doesn't survive that process, not that it's causing any sort of problems later on.
So that's good news that taking those 3 cells or so to do that genetic assessment doesn't affect the future baby any different than the IVF process without genetic testing. But what about IVF itself? Does that process of creating that life, in the test tube, as they say, is an IVF baby zero difference in terms of any markers that have been studied over the years?
Yeah, that's a really good question and a really important point, because we actually, when we compare IVF pregnancies, whether they're biopsied or not biopsied embryos, compared to spontaneously conceived pregnancies, we actually do see just slightly higher risks of birth defects or other pregnancy complications, such as like preterm delivery or things like that. So many times people who have done IVF are actually getting a higher level ultrasound at 20 weeks, or maybe even get like a fetal echo to get a special ultrasound of the baby's heart during the pregnancy, even if that ultrasound at 20 weeks looked good. So again, every clinic is different in how they manage that, but because there probably are just slightly higher risks. Any pregnancy has about a 2 to 3% chance of a birth defect. If we think about IVF pregnancies, it's maybe like a 3 to 4% chance, just a little bit higher.
So very low, but measurably different than a spontaneously conceived natural pregnancy.
Correct.
Interesting. And I guess it's so multifactorial as to what goes into that, because I can think of our program. We probably have, I would bet, at most 5 to 10 families that have chosen the path of IVF and pre-implantation genetic testing to, install a mutation-free baby or embryo, at least mutation-free as far as the family's mutation. So not very many over the years. And again, I wonder if that's in part because I'm not afraid of them creating a child with long QT or whatever. And then I end up telling them, you know what, you could probably spend your $20,000 on jewelry instead. But those families who've done it, I must say, you have a wonderful team that you're a part of, because it's been an incredible experience. The way you hold their hand through what's not, which is a very unique journey. Most people don't do this path. As we wrap up towards the 4 minutes on the counter, probably for some families, a very delicate question then is, what happens to that A+ embryo who tested positive for mom's LQT2 or dad's LQT1? Does that A+ embryo go in the deep freezer forever?
Yeah, good question. It's always a kind of a personal decision for that patient or for that couple. That is one option, is just to keep those embryos frozen indefinitely. Of course, there are fees you have to pay for embryos to be stored in a cryo bank. Some people make a difficult decision to discard those embryos. They maybe have the laboratory safely discard them. Sometimes people will have embryos that, sometimes people have done special things where they've been able to bury their embryos or create jewelry with the embryos in them. So, there's a lot of unique things that people can do, but I think that's a really important thing to think about before you get all through this process is, it is a 50-50 chance, but in theory, you could flip a coin 10 times and land on heads 10 times, right? You could end up with all of the embryos having the mutation. And so are you comfortable transferring those embryos with the idea, maybe we do this in hopes of having embryos that don't have the mutation, but if that's all we have, we would still transfer those embryos knowing that they have that mutation. How do I feel about discarding those embryos knowing they could be just like me, right? I think that's a really hard thing to wrap your head around. And again, everybody has their own kind of thoughts and personal feelings on that.
Right. Well, this has been, we could go on for hours, literally. And I imagine the SADS community will want us to do this again. And I do hope you'll join me again. But a real quick one, because Martha's asking a great question. We covered it, but let's just do it to close, when she's asking, do we test for the exact mutation type that the positive mom has, or let's say the positive dad has, or does her mutation have to be in the library? And again, you'd said, and what we know is the embryo gets tested for, do they have the right amount of chromosomes, the whole collection, and then also, does the baby own, yes or no, the one specific disease causative variant that the mom possessed or the dad possessed?
Yes, correct. And the laboratories that do this testing design a test that's unique to that person's mutation. There's more steps involved than we have time to discuss today, but there's a very unique, we call it a probe often, that is developed for testing somebody's embryos that can't be used for anyone else in the entire world. Even like if you had a sibling that had the same exact mutation as you, that probe that's made can't be used for your siblings' embryos if they were to do the same thing. So there's a process where they review your mutation, make sure they feel comfortable. Yes, we can identify this. And then they create that probe that's unique to that individual's very specific mutation.
Fantastic. Well, Laura, thank you so much on behalf of the SADS Foundation and all the families. This has been wonderful. I've enjoyed it immensely. I learned a lot, and so I really appreciate you. I appreciate your role here at Mayo Clinic, and just thank you for all of us at the top of the hour. Now, a quick announcement: we will be coming together in 3 weeks, not 2 weeks, because my daughter graduates from college in 2 weeks. So we'll be together again on May 10th. Mark your calendars. Another calendar to mark is April 25. There's going to be our Drugs to Avoid webinar for individuals with long QT syndrome. And then also a reminder, we are making great progress raising the funding and the money for this incredible meeting that we'll be having in just a couple months now with the FDA, for the FDA to hear from you on long QT syndrome and CPVT. And that's going to shape the future of developing novel therapies for these diseases. So wonderful to be with you. We went 1 minute over for like the first time ever, but I think it was worth it because that conversation with Mrs. Laura Rust was fantastic. So again, Laura, thank you so much. And to all of you out there, can't wait to see you again in 3 weeks and join us at that time on May 10th. Bye, everyone.